Today we are going to discuss about radius and trauma to radius. I am Dr. Parvez Ahmed Rishi. I am not associated with any department or any medical college or any institution. I am doing everything for free. I don't accept any money. I don't give any money. I don't give any surprise gifts or any notes, or I don't sell any books. And these lectures are free, and I do it for the educational purposes only. And for those students who can get any help from these, they can just watch, and they can like and comment and subscribe. Thanks to all those who have subscribed and liked and posted good comments. Thanks a lot. If you have any question, you can ask, and I will try to get back to that question. Okay, let us start. So let us start with the PA view of wrist. This is the PA view of wrist. It shows the carpal bones, and it shows the phalanges. It shows the here the we are mainly concerned today with the radius. You see the outline of radius here. You can watch the outline of radius here. This is the radius bone, and today we are going to focus only about the radius. This is the lateral view of radius. You can see this is the lateral view of radius. Is the normal, so you see the normal contour of the radius. From here, radius starts from there, and this is the radius bone. Now let us have distal radius. So what is about distal radius? The articular surface of distal radius has two concavities. So we have the lunate facet here and the scaphoid facet here. So we have two parts. So this is the one part, this is the scaphoid facet, and this is the lunate facet. This is the Lister tubercle of Lister. This is radius, this is dorsal, this is ventral and volar. Okay. This is styloid process of ulna, and here we have triangular fibrocartilage. We know that the radius lies laterally and the ulna lies medially. Okay, so this is the ulna styloid process. This is the vascular lamina. Okay, and this is the lunar facet. So articulates with the lunar bone, and here this is the scaphoid process. Vascular vascular foramina, and here the volar tubercles are here. Okay, so it is written so thin. Now let us come to the articular surface of the radius has two cavities. One of the articulations with the scaphoid and one of the for the lunate. The two facets are divided by a ridge running from distal to volar. The surface is triangular in shape with the base formed by the notch, the tip, and etc. Now axial load sharing. What is axial load sharing? Distal radius axial load sharing is by distal radius 80%, ulna and TFCC by 20%. TFCC, it is triangular cartilage, radioulnar ligament, dorsal and volar. It is ulno-lunate and ulnotriquetral. The ligaments through ligament to taxis facilitates reduction of the distal radius fracture. Volar ligaments are stronger than the dorsal and confer more stability to the radiocarpal articulation. Now you can see here we have the TFCC acts as stabilizer of distal radioulnar joint. This is the here scaphoid. Okay, we had some specs here. The ulnar head does not articulate with the carpal, and ulnar head does not Corpus at the TFCC extends from the ulnar aspect of the radius to the base of ulnar styloid and articulates with the triquetrum. Okay. When patient falls on the outstretched hand, the mechanism of injury most common fall on outstretched hand with the wrist in dorsiflexion. Dorsiflexion, wrist in dorsiflexion, like this. Dorsiflexion, you can see this is the dorsiflexion. Wrist in the dorsiflexion, we fall on the wrist. We fall on the outstretched hand. Okay. Presenting symptom is pain, swelling, ecchymosis, restriction of movement, symptoms of carpal tunnel, compression and median nerve injury, deformity at wrist. The classical dinner fork or silver fork deformity is caused by dorsal displacement of the corpus, secondary to the distal adjustment angulation of the distal nerve. So this is, you can see this is the distal fragment. The classical dinner fork or silver fork deformity is caused by dorsal displacement of the corpus secondary to the dorsal angulation of the distal radius. So this is the distal radius. It is, you can compare it with the dinner fork or with the silver fork. Here you can see the distal fragment has displaced dorsally. As you know that there is no shortcut to success. Any video through which you want to run and get a short burst of knowledge, there is no such video. You have to give your time and listen patiently, and only then you can make some concept for lifetime. Important radiological point. What is the important radiological point? You can see that this is the distal volar rim. This is the volar 11.2 angle. This is the 11.2 angle. Volar angle. This is radius. Okay. This is dorsal. This is distal dorsal rim. So this is the dorsal rim. Okay. Dorsal palmar tilt. Dorsal palmar tilt on a true lateral. It is drawn connecting the most distal, the volar and the dorsal tip of the dorsal or palmar tilt is angle, that line drawn along the longitudinal radius. So we draw the line along the longitudinal radius and then we measure the angle. Okay. So we have measure of the radial length and inclination. Inclination degrees are 23. So this is the 11-degree angle. Here you can see this is x. What is x? Normal x is equal to 11 to 12 mm. This is 11 to 12 mm normally. Range is 18 to 8 to 18 mm. Radial length, this is measured on the PA radiological radiograph. We measure it on the PA. So we measure it here. This rim, this x, it is usually 11 to 12, and range normal is 11 to 12, range is 8 to 18. This is median on PA radiograph. It is distance in millimeters between the line drawn perpendicular to the long axis of radius. Okay, long axis of radius, and tangential to the most distal point of ulna. Tangential, and a line drawn perpendicular to the long radius and at the level of tip of radius. Ulnar variance. Ulnar variance is radial length, ulnar variance. So this is This is measure of radial shortening. So why we do ulnar variance? This is ulnar variance. This is a measure of radial shortening. Vertical distance between a line parallel to the medial corner of the articular surface of radius and a line parallel to the most distal point of articular surface of the ulnar head, that is this line, both of which are perpendicular to the long axis of radius. This is the long axis of radius, and these are the two lines, and this is the ulnar variance, most distal point of the articular surface of ulna, both of which are perpendicular to long axis. So this is, now you know what is ulnar variance. This is the ulnar variance, and this is RL, radial height. This is radial height. So this is ulnar variance, this. Okay. Now the radial inclination, you can see this is the radial inclination line through the articular surface of radius and a line. So it is usually up to, on a PA view, the radial inclines towards the ulna. This is measured by angle between a line drawn from tip of radial styloid process to the medial corner of articular surface, of the radius, and a line drawn perpendicular to long axis of radius, It is the angle. So we do draw a perpendicular from this point, we draw a perpendicular and we measure the angle between these two lines. Okay, clear so far? Now we have teardrop angle. What is teardrop angle? The teardrop angle refers to angle between the central axis of volar rim of lunate fossa and the central axis of radial shaft. Teardrop angle to less than 45 degrees indicates displacement of lunate facet, failure of reduction. AP distance measure of articular incongruity and is defined by the distance between the apices of the dorsal and the volar rims of the lunate facet. The normal AP distance averages 19 mm on the true lateral view. Now the teardrop angle is, this is the AP distance here. Now this is the teardrop angle. So we heard what is the teardrop angle. This is the longitudinal and this is AP distance, anterior-posterior distance. This is teardrop angle. You can see this is the teardrop angle. So this is teardrop angle. Okay. Now we have other injuries associated with distal radius. What are other injuries associated with distal radius? This is the ligament 1 ligament. This is triquetral chondral ligament. So we have interosseous ligament injury. Now you can remember that the Gilula's carpal arcs formed by proximal and distal, proximal carpal, radial and cortical margins of hamate. TFCC injury, interosseous TFCC injury. Now we have normal wristolateral carpal alignment. Now see the carpal alignment, two lines should cross within the carpus. This is the two lines. One is the line along the long axis of capitate, and another line through the carpus cross these two lines, the longitudinal line through the radius and the long axis of capitate. They both should pass through the carpus. You can see here. So now normal wrist lateral. In most cases, carpal malalignment after distal radius fractures are caused by residual dorsal or volar tilt of the dorsal radius and not by intrinsic instability of the corpus. As the radius tilt off, for example dorsally, the lunate tilts with it. The position of the hand is corrected at the mid-carpal joint, resulting in the carpal malalignment. So the normal value is radial length is 8 to 18 mm, radial inclination is 13 to 30 degrees, and palmar tilt is 0 to 28 degrees. The radiological limit beyond which correction is recommended. We have radiological measurement limits. Positive variance, ulnar variance 2 to 3 recommended. Carpal malalignment, neutral of carpal. Dorsal tilt, malalignment and less than 10 degrees, carpal aligned. Now we have DISI and VISI deformities. What are DISI and VISI deformities? Now dorsal intercalated segment instability, dorsiflexion, carpal instability. And then we have VISI, it is volar intercalated segment instability, volar flexion, carpal instability. The intercalated segment is the proximal carpal row identified by the loop. The term intercalated segment refers to it being the part in between the proximal segment of the wrist consists of radius and the ulna and the distal segment represented by the distal carpal. So all this means is that in DISI or dorsiflexion instability angulated dorsally, if lunate is tilted, measure the scapholunate angle 30 to 60 degrees. 80 degrees is the questionable abnormal, greater than 80 is abnormal, and less than 30 is normal. DISI is due to disruption of the scapholunate articulation. When the scapholunate joint is dissociated, the scaphoid is palmar flexed and the lunate is dorsiflexed. Most common mid-carpal instability due to scapholunate ligament tear, increase in scapholunate angle. VISI or palmar flexion instability is when the lunate is tilted palmarly too much. VISI is secondary to disruption of the lunate and tricuteral due to posterior subluxation of both scaphoid and lunate that remain interdependent due to lack of lunotricuteral. Okay. Now we have, you can see RC, IC, UC, 1, 2, 3. The radial column RC includes the radius steroid and scaphoid process, fossa. Three-column concept. What is three-column concept? The intermediate column IC consists of the lunate fossa and sigmoid notch distal lunar joint DRUG. The ulnar column comprises distal luna, DRUG and TFCC. The radial styloid is an important stabilizer of wrist, gives attachment for extrinsic carpal ligaments. Only a minor amount of load is transmitted. Large proportion of load is transmitted across lunate fossa. To the intermediate column, the radius swings around the luna and two big bones are firmly linked together by ligaments at the level of proximal and distal radioulnar joint by the interosseous membrane. The ulnar column UC, DRUJ and TFCC allows independent flexion, radial ulnar deviation and pronation supination of the wrist. Frickman classification. Distal ulnar fracture absent and present. Fracture, we have Frickman classification, so 1 and 2. Okay. Extra-articular, so the type is 1 and absent it is type 1, so present it is 2. Intra-articular involving radiocarpal joint, it is 3 and 4. Intra-articular, you can see 1. So it is absent. Now if it is present, it is 2. See, this is 3, this is 4, type 4. Intra-articular involving radiocarpal joint. So this involves radiocarpal joint. If it is absent, it is 3. If it is present, it is 4. Now 5, we have intra-articular involving DRUG. It is 5 here if it is absent, and if it is present, it is 6. Now we have here intra-articular involving radiocarpal and DRUGC, radiocarpal and UGC. If it is absent, it is this, and if it is present, it is this. Distal ulna fracture, absent and present. Fernandez classification type 1, 2, 3, 4 and 5. Metaphyseal bending. So this is metaphyseal bending. It is type 1 with loss of palmar tilt and radial shortening. There is radial shortening, there is palmar tilt. So this is metaphyseal bending. Type 2 is shearing fracture. This is shearing fracture. This is type 2. Requiring reduction and often buttressing of articular segment. Type 3 is, this is, you can see, compression of articular surface without characteristic fragmentation potential for intrusous ligament injury. Type 4 is avulsion fracture. There is avulsion fracture or radiocarpal fracture dislocation. Type 5 is combined injury with significant soft tissue involvement. So we have, this is 24. We have eponium, this Colle's fracture outward. This is Colle's fracture. And we have Smith's fracture inward. When the hand is outward and person falls, hand is outward, what results? It results in Colle's fracture. When hand is inward and man falls, Smith's fracture occurs. Colle's fracture fall on hyperextended, radially deviated wrist with forearm in the pronation. Extra intra-articular distal radius fracture demonstrating dorsal angulation, dorsal displacement, radial shaft and radial shortening. So we have dinner fork deformity fracture, dinner fork deformity. So we have Colle's fracture, fall on the outstretched hand, pronated hand, outside, outward, fall on hyperextended, radially deviated wrist with forearm in pronation, extra intra-articular distal radius fracture, demonstrating dorsal angulation, displacement, radial shift and radial shortening. Smith fracture fall on flexed wrist with forearm fixed in supination, volar angulation, volar displacement. Okay. Barton's fracture. This is the Barton's fracture here. Fall onto dorsiflexed wrist with forearm fixed in pronation. Fracture dislocation or subluxation of wrist in which volar or dorsal rim of a distal radius is displaced. Radiological fracture, Chauffeur's, backfire, Hutchinson's fracture. Avulsion fracture with extrinsic ligament remaining attached to radial styloid due to direct blow, compression of scaphoid against the styloid with wrist in dorsiflexion and ulnar deviation. You can see the fracture. This is radial styloid fracture associated with intercarpal ligament injuries, scapholunate, perilunate dislocation, or if often necessary. Fracture affecting treatment, local factors characteristic of bone, soft tissue and fracture. Patient factors: age, lifestyle, occupation, dominance, medical condition, other injuries. Radiological parameters and carpal ligament. Carpal ligament. Now we have non-operative. All fractures should undergo close reduction, even if the expected that surgical management will be needed. Help to limit post-injury swelling, provide pain relief compression on the median nerve. These are helpful. Post-close reduction slab cast has to be applied. Frequent radiograph examination is necessary. Loss of correction. Hematoma block to close reduction. Candidates of non-operative management: patients with non-displaced or minimally displaced fracture, displaced displaced fracture with stable fracture pattern, which can be expected to unite with acceptable radiograph parameters, low demand elderly patients. You can see here we have given different radiographs with these are the normal. Then we can see here the slab, we have put the slab, and we have done repeated x-rays, repeated radial x-rays, lateral view, and we can see that bone is healing, the healing is taken place, fracture line has disappeared. Operative management indications: high energy injury, secondary loss of reduction, articular metaphyseal communication, bone loss, DRUG incongruity, open fracture, associated carpal fracture with neurovascular injuries. Mainly three types of operative management: percutaneous pinning, external fixation, open reduction and internal fixation. Percutaneous pinning, use of extra-articular minimal articular distal radius fracture, generally used to supplement arm casting or external fixation, may be accomplished by K-wires across the fracture. Kapandji intrafocal pinning. On the radial side, Kapandji intrafocal, you can see on the radial, this is called Kapandji intrafocal pinning. On the radial side, the pin is inserted in the plane between the tendons of extensor pollicis brevis and abductor pollicis longus. The posterior lateral incision is placed slightly lateral to the above Lister's tubercle, and the pin is placed between EPL and the tendons of EPB and APL here. The posteromedial placement is usually between extensors of ring and the little finger here. The pins are introduced perpendicular to the fracture, oblique upwards and buttressing the cortex of the distal. The pin is then driven into the opposite cortex of the radius. External fixator. So we can put the external fixator. Bridging external fixator indications. We have the non-bridging external fixator indications. This is non-bridging. This is bridging. Fracture with instability, extra-articular or minimal articular fracture, especially where the distal fragment is too small to allow non-bridging external fixation. It can also be used to serve articular fracture. See below the opening injuries. Non-bridging external fixator indication: undisplaced or reducible closed There must be sufficient space in the distal fragment to the pins. Usually requires intact volar, the technique used for displacing fracture and इतना. Bridging and non-bridging. Pins in the second metacarpal and the radial shaft, thus bridging the radiocarpal, intercarpal and carpometacarpal joints and depend on the ligamentotaxis. Non-bridging external fixation employs pins in the distal fragment of the fracture and in the radial shaft and allows distal fixation of the fracture. Now we have bridging external fixation, pitfall and prevention. Pin track infection. Ensure no skin tension. Insert pins by hand, not power. Over distraction. Examine fluoroscopic view for the radiocarpal gap. Loss of reduction malunion. Always augment. Use minimal open reduction if close reduction falls. So hand stiffness, physiotherapy, radial nerve injury, open pin placement, non-bridging external fixation, pitfalls, over reduction by way if volar communication, bayonet, volar cortex, tendon injury, open distal pin placement. Palating, popularized for volar displaced distal radial fractures by a palate which was placed on the volar surface of the radius and acted as a buttress to prevent volar displacement of the distal fragment. The problem of maintaining the reduced position of the dorsally displaced distal fracture as first tackled with dorsal palating. The technique was designed to buttress the dorsally displaced fracture but had problems with soft tissue complications. Volar locked palating were introduced to stabilize dorsally placed fractures. Now is the most popular method of fracture fixation. Modified Henry approach. What is modified Henry approach? Approach between radial artery and FCR tendon. Here, this is radial artery and this is flexor carpi radialis tendon, flexi pollicis longus tendon, flexi carpi radialis FCR between this and this tendon. Modified Henry approach. This is modified Henry approach. In line with the FCR tendon, the tendon is then retracted ulnar direction and an incision made in the floor of the fossa sheath that exposes the FPC belly, which is swept to ulnar side, and fibers of pronator chordates are then evident by release of the radial side of radius and elevated. Palmar motor branch you can view. Palmar sensory branch of median nerve. You can see we have pronator quadratus muscle, median nerve here. Main limitation of this approach is visualization, volar ulnar corner of the distal radius. Where there is an intra-articular fracture at the volar ulnar surface corner, it is mandatory to capture that fragment with the palate. In these circumstances, an approach between the flexor tendons and ulnar neurovascular bundle should be used. The incision for this approach is more ulnar over the ulnar border of palmar longus and then need to mobilize flexor tendon and ulnar neurovascular bundle. Advantage of volar palating. Anatomical reduction of volar cortex facilitates restoration of radial length, radial inclination and volar tilt, preserves the vascular supply to the dorsal fragment. Because the implant is separated from flexor tendon by the pronator quadratus, the incidence of flexor tendon complication is lessened. After stabilization, shortening and secondary displacement of articular fragment is improved and the need for bone grafting is reduced. Pitfall of volar plating. Pitfall of volar plating. Fracture, collapse, malnutrition. Prevention. Beware of over-reduction of volar displaced fracture if dorsal communication is present. Ensure volar ulnar corner fragment captured by plate. Avoid screws by in sagittal intra-articular fracture. Augment with bone substitute graft of large metaphyseal defect. Tendon injury. Reduce measured size of distal screws by 2 mm. Ensure proximal screws not prominently dorsally. Ensure distal end of palate is proximal to watershed line. Look for signs of tendon irritation post-operative. Joint penetration by screws. Intramedullary fixation. Micro nail through the incision made over the radial styloid. Take care to avoid injury to the branch of radial sensory nerve. The interval between the first and second dorsal extensor compartment is used. Dorsal nail palate approach is performed through a limited dorsal incision centered over the extensor. Advantages: increase fracture stability, allowed load transfer across the fracture, minimal soft tissue problems by maximizing scarring and adhesions, maintain vascular blood supply to promote fracture healing. Disadvantage: possible screws, penetration into the distal radioulnar joint, arthroscopically assisted fixation. Provide a minimally invasive way of monitoring close reduction with percutaneous pin fixation. Assess of articular joint surface as well as diagnosis of introsseous carpal ligament injury to TFCC injury. Facilitate as the excision of osteochondral flaps and lost bodies as needed. Steep learning curve too soon, often injury may face difficulties with fracture, hematoma, impending articular visualization, fracture treated after 1 week from injury and difficult with wires. Bioabsorbable implants made of polylactic acid and polyglycolic acid.